Thanks for coming. So the future of healthcare of nearly 80 million Americans is uncertain, and options and opinions are fiercely divided over what recent tighter governmental controls will say for the future of Medicare. This can all be verified from a famous senator's website, WebData. The website's called Medicare by the Numbers. Medicare is the United States federal health program available to people age 65 or older who've been on Social Security disability insurance for at least 2 years, and for people with ESRD, which is end-stage renal disease and kidney failure and regular kidney dialysis, or just 65 years or older. That's at least how the CMS website, which is the Center for Medicare and Medicaid Services, languages who is eligible for Medicare. Since Medicare's inceptions, doomsayers have derided the program as inefficient, socialized medicine and doomed to fail like all government programs. Senator Burr's informative statistics, that's from the website I talked about, support that indeed Medicare now serves over 50 million Americans, and that figure is expected to grow to nearly 80 million by 2030. Over 10,000 people turn 65 every day from now until then. It's kind of crazy, huh?
Yeah.
Deficits in the program are estimated as high as $7 trillion, and there's probably close to $100 billion in Medicare fraud annually.
Fraud.
$100 billion.
Well, I didn't know
I would believe
I didn't know
that.
ESRD was a part of their standard.
Yeah, what will happen? What will happen? I have a personal concern about this as an American and as a breadwinner. My work is related to Medicare, and one in which I take great joy. For the past 5 years, I've served as an insurance agent who specializes in Medicare plans, including Medicare Part D prescription drug plans, Medicare Supplement or Medigap plans, and Medicare Advantage plans, which are a type of managed care plan implemented by private insurance companies. I jokingly refer to myself as 40% paid insurance agent and 60% unpaid social worker. Since I work with the Medicare population every day, helping them choose the right plans, helping them apply for assistance they aren't aware of, and trying to save them money on their out-of-pocket costs while getting better access to care. Yes, this makes up part of my livelihood, but more importantly, I see firsthand how desperately important this healthcare program is to the people who not only help pay for it, but who every day rely on it for their well-being. Today we'll discuss what relevant sources have to say, good and bad, about the Medicare program, recent changes, and its uncertain future. First, we'll look at the good news. The Center on Budget and Policy Priorities reports that Medicare is not bankrupt. Though naysayers have predicted the financial collapse of Medicare since its inception, the lifespan, on paper at least, for the survival of the program has gotten a recent boost. Despite all the punditry on what is popularly called Obamacare, the Patient Protection and Affordable Care Act of 2010 has done much to expand the expected solvency of the Medicare system. The Center for Budget and Policy Priorities reports that when one drills down into the numbers, it is really only the hospital benefits of Medicare that have long been in question from a solvency point of view. This is called Medicare Part A. Medicare Part B, or routine medical care, is fiscally safe for the long haul currently on paper. Due to the changes made in how hospitals are compensated and potentially penalized, though, the Affordable Care Act has, since its full implementation in 2014, the expected solvency of Part A has been elevated to 100% until 2030. At that time, Medicare Part A is still estimated to pay up to 85% of the full benefits from that point forward without any more changes. So while benefits could change, collapse seems unlikely. Further implementation and improvement of the ACA can potentially extend the life of the program even longer. Remember, the CBPP, that's the Center for Budget and Policy that I talked about something, is a nonpartisan watchdog agency, and these numbers relate one good thing about what people often negatively call Obamacare. Most people don't know that in many ways Medicare is very cost effective. As Stephen Brill aptly points out in his Time magazine article, Bitter Pill, though we've all heard the horror stories about hospital charging Medicare $1.50 for every aspirin, most items from Medicare have been whittled down to Medicare allowable expenses, which are often much lower than private insurance charges, and Medicare no longer allows for things like metaphorical $1.50 aspirin. Mr. Brill further reports that Medicare has also begun to crack down on some of its biggest costs, fraud and poor hospital practices. Part of the ACA invested more money into Medicare fraud detection, an area that has been chronically underfunded. The ACA also created penalties for hospitals with a high rate of readmission within 30 days. What does this mean? It means that if the hospital sends you home before you're better, or without a good plan for discharge, or if you get an infection at that hospital while you're there and you have to be readmitted because the hospital actually made you sick, that facility and group could face consequences including fines, reduced reimbursement rates, and even potential exclusion from the Medicare system. From an administrative point of view, Medicare is much more cost-effective than private companies. The average administrative claim through a private insurance company, so how much does every claim cost, and administrative costs and salaries and CEO and stuff? $25. With Medicare,
$250.
18 cents for the same claim.
Wow.
That's a big difference in overhead, and yes, part of the
Wonder
bitter
hospital makes healthcare.
yeah, part of the that's the administrative cost, not to the hospital though.
Oh,
The
gotcha.
claim just within
Just to process
Just the
the
process.
claim.
within the private company
Gotcha.
versus they use private contractors with Medicare. So yeah,
18
forget
cents versus
forget the
25
amount that they pay.
Got
You know, that's different. Yeah, that's a big difference, and yes, part of the bitter pill involved in digesting the details of our current medical industrial complex. Actually, the Annals of Medicine Journal reports Medicare is moving away from a fee-for-service model to a value-based model of compensation. What does that really mean? Now, physicians and facilities are paid based upon what services they do for a patient. If a facility or provider wants to make money from Medicare, they can simply add more services, more visits, more tests, more scans, even more surgeries. The new model will start to pay doctors and providers on better health outcomes rather than on the amount of services that a patient receives. This means that, for instance, if your doctor has more patients who end up healthier for longer, he or she can receive bonuses and higher reimbursements for those improved health outcomes rather than on the amount of work, tests, visits, etc. that the patient receives. This will shift payments from a volume-based system to a value-based system. More healthy people instead of more services will mean more money to providers and facilities and more savings for taxpayers. That has to be a good thing, right?
Yeah.
With all this said, according to the New England Journal of Medicine, the future of Medicare system is still uncertain. The model for the ACA forces more Americans to get health insurance prior to Medicare and work with a primary care physician toward preventative care. The nation has already had a well-known shortage of primary care doctors, and now more are needed. Who's going to care for all these people, huh? Congress has capped fiscal support of graduate medical training, and the journal reports current congressional gridlock shows no quick change of that in sight. The journal further points out that due to additional federal and state budgetary cutbacks, similar state-funded programs for similar education has also been reduced. This means we have a system that more than ever relies on primary care physicians, that we don't currently have enough primary care physicians, or PCPs as they're called, and there isn't sufficient government support or college enrollment to indicate that these trends will change anytime soon. Anecdotally, you know this, I can tell you that this year on my tiny island with a population of around 60,000, we have a doctor shortage. Estimates indicate we could use between 4 and 10 new primary care physicians on Kauai alone. Every day, many physicians are retiring, and people are moving here and often can't even find a doctor in the phone book, or they call every doctor in the phone book only to find that no one's accepting new patients. The good news is 4 more doctors have been hired by Kauai Medical Clinic, so I hope this trend will continue to come to an end here, at least temporarily. Is this a sustainable model from a manpower point of view nationwide? Who knows? That aspect of our healthcare and Medicare system doesn't look great right now, though. Despite these challenges and unknowns, the future of Medicare may be better than most political pundits predict. In his famous New York Times column, noted economist Paul Krugman in August of this year reported what he called Medicare miracles. The first trend he reported is that due to the ACA or Obamacare, health spending has slowed severely, with Medicare spending at least $1,000 less per beneficiary than the CBO had predicted just 4 years ago. Mr. Krugman sums up this with 3 conclusions. First, the Medicare fiscal crisis has at least been postponed. Second, though the economy has recovered in many ways, medical spending has not increased at the same rate as economic growth, which is a good thing because many people were saying, well, the only reason medical spending is down is because the economy is slow, and as the economy picks up, the spending will pick back up. Well, a lot of economic indicators have picked up, but medical spending rates have not increased to the same thing. All this is a good thing. His general take on moving toward healthcare for all his general take on what moving toward healthcare for all means, based on this new data, is a slogan that hasn't been heard with enthusiasm since at least 2008 or 2009. Yes, we can. Remember that? For now, it looks like I have a job. That's a good thing for me and for my family, and probably for Milano Pono. For the nation and Medicare, it could mean a better future too. Though as recently as this year, the LA Times ranked the U.S. as dead last of 11 developed countries and their healthcare systems, despite our spending more per person than any other of those systems. At the same time, though, Karen Davis, a researcher at the Commonwealth Fund, stated, "With the enactment of the Affordable Care Act, we have entered a new era in American healthcare. May we become healthier as a nation, physically and fiscally, over our future, no matter how long it takes." So, thank you for your attention. Yay.
Excellent.
No questions, please.
No,